2018 as a professor of social work in the Westbrook College of Health and Professionals, and as the founding director of the new university-wide Center for Excellence in Aging and Health. And I will note that the center is sponsoring a part of this ECHO, actually. Tom is a clinical psychologist with specialized training and experience in narrative gerontology, the neuropsychology of dementing disorders, and psychosocial intervention approaches to enhance well-being in later life. He has an extensive and very impressive work history and is known for his work in loss and grief and dementia caregiving, older driver fitness, and reminiscence and life review. His latest research focuses on legacy beliefs in older adults and cross-generational communication about what matters most in life. And he is going to talk with us today about driving and dementia. So Tom, I'm going to turn it right over to you.
Great. Thanks so much, Jess. Jonathan, were you able to get up the email slides I sent?
Yeah, you're all set and queued up on your first slide, the dementia and retirement for driving slide.
Great. Well, it's a pleasure to be here. I had a meeting with the team that's doing the Healthy Brain Initiative through the Maine CDC that I didn't want to pass up the opportunity to talk to them, but it means I'm sitting in their conference room on a very weak public Wi-Fi, which means that you just hear my voice. I can't share video. Tried and it didn't work. So for the last 20 years of my career, I've been engaged in work around the issue of driver fitness and aging, particularly the issue of dementia and driving. And as the title suggests, the decision to retire from driving is an inevitable one when it comes to Alzheimer's dementia, but I would argue really for any of the common dementing conditions. And so what I want, next slide on agenda, I want to just start by highlighting one of the items that's in my very long handout packet. We're going to watch a video of Mr. Green, a gentleman with mild to moderate Alzheimer's disease, and engaged in a traffic stop. And I'd like you to notice some things there. We'll talk just a little bit about driver licensing in Maine, and then we'll finish with some hopefully practical materials that you can take with you and use in your local areas. So next slide. This is one of the pages that is in the handout packet. It's from a book chapter that I wrote on driving and dementia a few years ago. And the idea is to link the stages of change model, or the trans-theoretical model, which originated in understanding how people manage addictions. It's actually a really nice model with respect to understanding the transition and what happens on the individual level as a person becomes aware of a driver safety issue all the way through to what can happen later. And this provides, I think, a rubric for professionals to think about, one, the staging of an older adult client or patient on the issue of driving and dementia, but also some action steps and what to expect in the future. So one of the tools that we'll mention at the end of this talk is listed there by the acronym ARMT, and that's a tool that I led a team to develop to help assess essentially a person's attitude set with respect to driving fitness and aging, and the larger issue of retirement from driving and finding an alternate way to be mobile. So we'll come back to that later. I just wanted to make mention in case I run out of time. Next slide. So this is Mr. Green. You'll see some questions on the screen. I'm going to ask that Jonathan activate the video. Jonathan, we're going to run it till about 4 minutes in. So when it hits about 4 minutes, go ahead and stop it, and we'll have a brief discussion. But pay attention to how Mr. Green behaves, and pay attention to what the officer does in response.
I saw your lights. What's wrong?
I need to see your driver's license, proof of insurance, and registration, please.
Driver's license?
Yes, sir.
All right. I didn't do anything wrong. I wasn't drinking or anything. What else you want?
Your insurance card and registration, please.
There's the insurance. I don't know where my registration is. I don't know. Maybe it's at the bank or something.
Well, the reason why I stopped you this morning, sir, is because you keep swerving across the center line.
Oh.
And then yes, sir, and you just ran a stop sign.
Well, I sure didn't see a stop sign.
Okay. Where are you coming from?
Coming from home.
What's your home address?
Well, I actually live in Madison, Wisconsin.
Madison, Wisconsin?
Yes.
And you got a Missouri driver's license?
Yeah.
Okay. What's your home phone number?
608 266 4615.
Okay. Are you sleepy, tired? You take medicines?
No.
Okay.
No,
Any reason for you why you're swerving and weaving?
No, I didn't know I was doing that, sir.
Okay. Haven't had nothing to drink today then already, have you?
Oh, no. No, I don't drink too much. No.
Okay. And what's your home address here in Missouri?
Well, I'm staying with my daughter.
Okay.
But I don't know what her address is.
How long have you been there?
Oh, just a little while.
What do you call a little while?
Oh, maybe a couple of years.
Okay. Would you step out for me, please?
Well, if you want.
And you just walk back there to the front of that patrol car, please.
Okay.
And off to your left.
Right here?
A little bit more down. That's good right there.
I still don't know why you pulled me over. I mean, I wasn't speeding. I'm not drinking or anything like that. I was just going to Steak and Shake.
No, I can tell you're not been drinking, Mr. Green. But the reason why I stopped is because you were swerving. You crossed over center line a little bit. But most importantly, as I was behind you, getting ready to stop you, you ran a stop sign.
Oh, you know? I don't remember seeing a stop sign.
It was coming close to the subdivision here. You ran a stop sign.
Oh, my God.
Mr. Green, could you tell me what day of the week it is?
It's Wednesday.
What month and date and year?
It's May 23rd, 2007.
Without looking at your watch, can you tell me what time you think it is?
Now it's probably, I don't know, 1 o'clock. No, can't be that. That's too late. 12 o'clock.
12 o'clock?
Because I'm getting late to meet my friends.
Okay, where are you heading to?
Steak and Shake to have lunch with my friends.
Which Steak and Shake are you going to?
The one up on Florissant.
Which part of Florissant?
I think it's West Florissant.
West Florissant? Okay. Well, sir, looking at the way you was driving, and you're not sure exactly what your address and stuff is here, do you have any memory problems or anything?
Oh, no.
No medical conditions?
No, not at all.
Okay. Do you have a phone number or someone that I can call to maybe come get you or get you a ride? Because I don't think you're safe right now to drive. Because if you're weaving, I don't know what the public's going to do. So I don't want them to hurt you either.
Yeah.
You have someone I can call.
Do you want to stop it about there, Tom? That's about 4 minutes 10.
Yeah, that's absolutely fine. So what was going to happen next is that he was going to ask Mr. Green if he had family, and Mr. Green was going to struggle to recall the name of his daughter. And there was going to be essentially sort of a negotiation where the officer was going to essentially drive Mr. Green to the restaurant and engage the daughter for assistance in this traffic stop. So I'm curious, we don't have a lot of time for discussion, but what stands out to you? Does Mr. Green seem like he has a problem? Anybody just jump in.
Definitely.
So what was the officer doing in this traffic stop to understand his problem?
I think he was calmly and very strategically trying to ascertain where if there was a memory issue, if it could have been another medical event happening. I thought he was doing a great job with that.
Thank you. So for time, we won't have further discussion, but so this was a training video. In fact, these are actors, although incredibly competent actors. This is a real highway patrol captain. And this was a training video to educate law enforcement in Missouri to use the data they had in their hands, like a license and registration, and the time of day, to do some down and dirty mental status testing, to essentially document when persons who were confused or having memory issues evident in conversation, they would actually be able to document more specifically so that the driver licensing process in Missouri could take into account these observations. It's not simply a traffic stop with an older adult, but it's an older adult who's having trouble remembering and putting things together. And Mr. Green, I think, represents an issue in our state of Maine of older adults maybe who've not been diagnosed with dementia, or maybe they have, maybe they live in a place where they absolutely have to drive. But I think this is an issue that is an important one. And I wanted to highlight the human side of it before talking a little bit more specifically on some of the data. So next slide. So Maine is very similar to most states in the United States. We organize our driver licensing under a Bureau of Motor Vehicles. Maine, unlike many states, has quite an active medical advisory board that adjudicates medical conditions with respect to aging. We start testing for vision at age 62. We're what's called a voluntary reporting state, where a physician or other professional who sees a problem that's medical is essentially, they're not absolutely mandated, except perhaps with loss of consciousness, to report to the state. So it's a should versus a must. Maine is a leader, next slide, in, though I think, providing means by which physicians and others can communicate medical information, such as dementia status, to the driver licensing authority. Advance it 1 and you'll see a functional ability profile pop up on the screen. This functional ability profile, I think, is relatively unique to Maine. Maine has, I think, 6 of these for different conditions. The one I'm showing on the screen is for dementia, and it provides guidance for health professionals with respect to driving to essentially grade their client or resident or patient with where they think they are with respect to driving safety. It's actually one of the strengths of Maine's driver evaluation process. Next slide. Maine's process has a number of interesting proclivities. I've been working to get to know the Medical Advisory Board. I spent 3 hours with them last November in Augusta, and I was quite amazed at the number of medical cases that the Bureau adjudicates in a single year. It averages between 8,000 and 10,000 cases. This is quite remarkable to me, coming from a much bigger state of Missouri, where they adjudicated roughly 1,500 cases a year. So Maine is doing 7 times or 6-7 times the amount of cases as Missouri, being much smaller. Maine is interesting in that in terms of its process of adjudicating cases, there are not a lot of deadlines or processes for accountability. A lot of it is based on your own self-report and your own willingness to follow the process. Something I found also fascinating is Maine is doing very little with cognitive aging and dementia with respect to driving. Other conditions are much more front and center. And quite honestly, with respect to driving and aging, I would say dementia, Alzheimer, and its related cousins, they are the #1 public health issues for driving. So if we go next slide, I'd like to run over just a few of the basics. Next slide. And then go ahead, Jonathan, and unveil all the text on this slide, please. We know that there are many changes in function and health-related changes that will impact on driving fitness and aging, and also non-driving mobility as well. I think it's important to recognize that a person can be non-ambulatory, maybe wheelchair dependent or walker dependent, and yet still remain safe to drive under certain circumstances. Compensatory strategies and assistive devices can go a long way. The field of occupational therapy has really taken a lead in helping people to work in this way, to remain behind the wheel safely. Roughly at any given time, I would say 10% of older drivers will have a driver fitness issue that may make them unsafe behind the wheel. Many will self-regulate and may even retire from driving with the support from family and friends. Some won't, and those that won't may be stubborn. They may be in situations, given where they live, that there are just no other options. I would say that a good portion of these individuals may also have cognitive decline. Timing is everything when it comes to this, and we'll come in a future slide talk about timing. Next slide. So we think about driving as involving a certain grouping of tasks and a certain grouping of abilities. So unveil the second bullet, please. So the tasks of driving, we learn early in life the operational aspects, and it's actually the operational abilities of driving that are retained the longest. And it's possible that somebody with mild to moderate Alzheimer's disease, like Mr. Green, could be tested and operate the motor vehicle correctly because of overlearned, almost automatic behaviors. With dementia, it's the strategic and tactical aspects of driving that fail first. So getting lost while driving is often a red flag of a problem. Also, making a tactical decision that doesn't fit driving conditions is another one of those red flags, even if operational ability is retained. Typically at the state level, what we care about most in terms of licensing is vision. So we set a minimum vision requirement. Very few states pay much attention, if anything, to assessing cognition or other sensory abilities. And so it really falls to the health and social service networks and families to pay attention to these other things with respect to fitness. Next slide. When it comes to safety and crashes, there's an interesting U-shaped curve that, or not U-shaped curve, but we sort of like this two-peak curve that we deal with. Of course, at young age, there is an issue with driver safety with respect to crash death. And that has to do with young people taking a lot of risks and perhaps having less experience. The same thing happens in older ages, but there's a real differentiation. If you'll bring up the text on the right side of the slide, Jonathan, we have a real issue where men are the primary problem. I hate to say it because I'm one. We have a sociological phenomenon in our country where women will tend to, in general, retire from driving early when the first signs of a problem appear. Men tend to retire late, often too late. But when women retire early, that also puts the pressure on men to stay behind the wheel. So one thing that we can do to help with driver fitness and safety in aging is actually promote ways to keep women driving longer, believe it or not. But men are the biggest risk, and men need to be, I think, a focus of the type of outreach that we do. Next slide. Another issue with respect to fitness and safety is who dies in crashes. If on this graph, the three groupings of bars to the right indicate the older group from 75 plus. In each case, those that are most at risk are the older drivers. So when you're a driver and you're 85 or older, if you're in a crash, you're at very high relative risk to passengers to death. And this is because typically of physical fragility and even just the impact of a crash at low speed can have a big impact on the musculoskeletal system and other functions of the older body. Getting hit by an airbag for an older adult can be like being in a crash without an airbag because the airbag itself can do damage. So there's a real benefit to older drivers who are physically frail to get off the road because of this risk. Dementia, next slide. I would say dementia is the top concern. The American Academy of Neurology really recommends that we act to move people into driving retirement at the mild stage of disease. Unfortunately, very few people get diagnosed at the mild stage still, even though we know a lot about how to diagnose the condition. Cliff Singer and his group would be the exception to the rule in terms of that early diagnosis. A big issue, though, with respect to diagnosis in primary care is trying to do too much too early. So when a person is diagnosed at the mild to moderate or moderate stage in primary care, it's not a good idea in that same appointment to make a recommendation to retire from driving. That's a really good way to lose a patient and to cause unnecessary distress. The reality is health professionals and social service professionals do not de-license. It is the state that does. We help facilitate the process, and it is a process. Next slide. The American Geriatric Society has a really nice guide called Assessing and Counseling Older Drivers that really takes, I think, a relative risk approach to looking at driver fitness in dementia, but across all the medical conditions. And it's not a yes, no, or a black and white kind of determination, but it's as I said, it's relative risk. Next slide. With respect to dementia, it's very important that screening, regular screening for mental status be incorporated into care when possible. Mental status tests are actually quite useful as triggers for a whole host of issues with respect to aging, but I would submit a decline in mental status is an important trigger to consider for driver fitness in dementia. Next slide. We're going to skip the risk stratification slide. We're going to skip the intervention in the community title, and we're going to go right to normalizing mobility transitions. And if you'd bring up all the elements on that slide, please. Something that we need to work with our clients and patients is to recognize that mobility is not monolithic. We're mobile in many ways. When we're young, we're mobile in terms of self-initiated walking or cycling, but we're also mobile on the road through our parents or schools, through public transit. During our working years, we are often driving our own vehicles. But it comes a time for everybody. If you live long enough, you will retire from driving. Doesn't mean you won't be mobile anymore. You'll be mobile in a different way. And so as social service professionals, we need to be able to work with our clients to normalize these transitions. We're going to skip the next 5 slides. So we're going to go through, and I apologize for all the animations. So I'd like you to come to the slide that reads frailty equals red flag for action, and bring up all the elements on that slide, please, Jonathan. So on this slide, and if you have it also on your computer screens separately, I know the text is small. The notion here is that Fred is somebody who's become frail at age 77. Eventually, though, at age 83, has a severe car crash and he dies, ultimately from the follow-up from that crash. The onset of frailty, physical frailty, even in the absence of cognitive change, is a major red flag that we need to consider for driving fitness. Next slide. So the tool that I've given you inside the handout packet, the Assessment of Readiness for Mobility Transition, or ARMT, is based upon a line of research, and you can see the papers. If you'll skip the readiness slide to the slide that shows the tool itself on the screen, please, Jonathan. This is a tool, I'm showing you on the screen the 24-item or long form of the tool, but there's also a short form as well. And it's in your packet. And the purpose of this tool is to help, either in an interview or done on paper, to help an older adult understand their own attitude set with respect to driving fitness. Next slide. So high scorers on this scale tend to be people who are I think, concerned about their aging and worried about loss of function to the point it really threatens them. And the prospect of decline, whether it be in mobility or another area of aging, is one that's problematic. And so if you hit them straight on with "you need to retire from driving," you're going to probably get a catastrophic response, and perhaps one where they deny and pull away from care. And so the ARMT tool is a way to understand the client's understanding of aging, but also of mobility change. In your packet, I have patient handouts that are written from a strengths perspective that take high, medium, and low ARMT scores and normalize these to help aid in the initial conversation with respect to driving change and aging. These are really nice tools to use with family as well as older adults together who are facing this transition. So you'll see then, we're going to skip the slide with the traffic light. I'm coming back now, looping to the slide, linking stages of change with intervention. So my point is here, it's not just the diagnosis of dementia, but it's the life situation and the beliefs and attitude set of the older adult and the family members that may surround them that are equally relevant to how you work with older adults with respect to retirement from driving. Next slide. There are some tremendous resources available online to aid in this, and I've given some of the links to these. The Hartford Insurance Corporation We Need to Talk guide is free online. They'll also send you free bound paper copies, really beautiful. Is a tremendous resource to be able to work in a planful way with families and older adults where driving retirement may be an issue. Next slide. The National Center for Senior Transportation has a wealth of information on its website. Next slide. Also, AAASeniordriving.com is a terrific resource. It has a particularly useful resource on the interaction of medications and driving. Many medications carry a risk for driving, but what do we do with that? This online guide can really help you consider that with a patient or a family member or client. Finally, I want to make note of a program called CarFit. CarFit is a program that helps older adults literally fit better in their cars, adjust mirrors, adjust seating. It's a program that can be taken to local communities, and you can organize CarFit events where people pull up to be fitted in their vehicles. It's an opportunity, say, for an age-friendly community in our area to engage with the public in a positive way on driving fitness that also opens a door for individual conversations for families or even older adults themselves worried about their own driving. I am done. Thank you for staying with me.
Thank you so much, Tom. That was really informative. I'm sure I speak for all of us to say that we learned stuff.